Okay, so good morning, everyone. Today we are going to continue with our book club on the fundamentals of diagnostic radiology with chapter 37 on the obstetric ultrasound presented by your colleague Dr. Faryad. May he start.
Good morning to everyone. Imaging methods. Ultrasound remains the imaging method of choice for dating the pregnancy. Transvaginal ultrasound is particularly useful in the assessment of first trimester pregnancy and in the demonstration of fetal anatomic structures deep in the pelvis. In the first trimester, the location and appearance of the gestational sac is documented. The presence or absence of a yolk sac and embryo is confirmed. The guidelines for the second and third trimesters define standard examination to include fetal presentation, amniotic fluid volume, cardiac activity, placental position, fetal measurements, fetal number, fetal anatomic survey, maternal cervix, and adnexia. Use of Doppler in pregnancy, evaluation of fetal and maternal circulation by color flow and spectral Doppler adds significantly to obstetric diagnosis. However, because all forms of Doppler involve the use of significantly higher levels of acoustic energy than conventional B-mode imaging, these modalities should be used with caution. When modern ultrasound equipment is used at maximum power settings for Doppler examination, acoustic outputs are sufficient to produce obvious biological effects, including tissue heating, cavitation, and tissue disruption, while thermal effects are more significant in the second and third trimester when bone is present, increasing sound absorption and heating. In first trimester, the first trimester covers the period from conception to the end of the 30th menstrual week. The embryo and the fetus have the greatest risk of maldevelopment, injury, and death during this period because of external factors like infection, drugs, radiation, or chromosome abnormality. Normal gestation. The early gestational sac can be seen by transvaginal sonography at 3.5 to 4.5 menstrual weeks as a tiny cystic structure implanted within the echogenic decidua, which is called the intradecidual sign. Ultrasound characteristics of a normal gestational sac: intradecidual sign before 5 weeks, double decidual sac sign after 5 weeks, well-defined round or oval anechoic sac, echogenic decidua thicker than 2 mm, position in the upper uterine body midway between uterine walls, and growth in MSD more than 1.2 mm per day. Yolk sac, which is 2 to 6 mm in diameter, always present when MSD is larger or equal to 20 mm on transabdominal ultrasound, or always present when MSD is larger or equal to 8 mm on transvaginal ultrasound. MSD. Embryo always present when MSD is larger or equal to 25 mm on transabdominal ultrasound, or always present when MSD is larger or equal to 16 mm on transvaginal ultrasound. A double decidual sac sign is evident in about 85% of normal pregnancies. The double sac sign is produced by visualization of 3 layers of decidua early in the pregnancy, which decidua capsularis, which covers the gestational sac, and decidua vera lines the uterine cavity, and a sonolucent dark line in between them, which represent uterine cavity. The yolk sac is 2 to 6 mm diameter spherical cystic structure that is connected to the midgut of embryo by a thin stalk, the vitelline duct. It's generally the earliest structure visualized within the gestational sac and serves as a definitive evidence of early pregnancy. The earliest demonstration of embryo is double bleb sign produced by the amniotic sac and the yolk sac with embryonic disc in between them. The corpus luteum develops on the ovary at the side of the dominant follicle. The wide range of normal appearance of the corpus luteum on ultrasound must be recognized for accurate diagnosis of abnormalities of the first trimester. In the first image is called a ring of fire on color Doppler, And the second image, the corpus luteum is collapsed, and in third is hemorrhagic, which contains a clot. Normal developmental anatomy of the embryo in the first trimester includes cystic appearance of the rhomboencephalon and herniation of the gut into the base of the umbilical cord. Between 6 and 8 weeks, the hindbrain rhomboencephalon forms a prominent cystic structure. Between between 9 and 11 weeks, the midgut herniates into the base of umbilicus, forming a physiologic omphalocele seen as a protruding midline anterior abdominal wall mass 6 to 9 millimeter in size. Abnormal pregnancy, vaginal bleeding in the first trimester, differential diagnosis, spontaneous abortion, and embryonic pregnancy, embryonic demise of a twin, ectopic pregnancy, subchorionic hemorrhage, implantation bleed, and gestational trophoblastic disease. Empty gestational sac, a gestational sac without an embryo demonstrated by ultrasound may be a very early intrauterine pregnancy or non-viable intrauterine pregnancy, which is called an embryonic pregnancy. A gestational sac is considered to be abnormal if it demonstrates the following features. Major criteria: absence of yolk sac when MSD is larger or equal to 20 millimeter on abdominal ultrasound, or MSD is larger or equal to 8 millimeter on transvaginal ultrasound. Absence of embryo when MSD is larger or equal to 25 millimeter on abdominal ultrasound, or MSD is larger or equal to 16 millimeter on transvaginal ultrasound. Distorted sac shape, growth rate smaller than 1 millimeter per day of MSD. Minor criteria: irregular sac contour, thin decidual reaction less than 2 millimeter, weak decidual echo amplitude, absent double decidual sac sign, sac position low in the uterus. Embryonic or fetal demise is diagnosed by ultrasound confirmation of the absence of cardiac activity. Absence of cardiac activity in embryos larger than 5 millimeter on transvaginal ultrasound is considered diagnostic of embryonic demise. Embryos smaller than 5 millimeter without cardiac activity should be rescanned in a few days to confirm viability. M-mode ultrasound is used to document visualized cardiac activity. Ectopic pregnancy occurs in only 2% of all pregnancies. Patients at high risk for ectopic pregnancy include those with a history of pelvic inflammatory disease, tubal surgery, endometriosis, ovulation induction, previous ectopic pregnancy, or use of intrauterine device for contraception. Most ectopic pregnancy, 95%, occur in the fallopian tube. Most commonly in the isthmic portion. Interstitial ectopic pregnancy, 2% to 5%, developing in the portion of the tube passing through the uterine wall, may grow to large size before rupture, resulting in catastrophic hemorrhage. Rare sites for ectopic implantation include the abdominal cavity, ovary, and cervix. A completely confident diagnosis of ectopic pregnancy can be made sonographically only when a living embryo or a gestational sac containing a yolk sac is positively demonstrated to be in a position outside of the uterus. When an intrauterine pregnancy is documented by ultrasound, the risk of coexisting ectopic pregnancy is extremely low, estimated at 1 in 30,000 cases. Ultrasound findings in ectopic pregnancy include demonstration of an extrauterine gestational sac appearing as a fluid-containing structure with an echogenic ring, the tubal ring sign, which is occur in 40 to 68% of ectopic pregnancy cases. The ectopic gestational sac must be differentiated from a corpus luteal cyst. A key differentiating finding is whether the cystic mass arises from the ovary. Most ectopic pregnancy occur within the fallopian tube and can be shown on real-time transvaginal ultrasound to be separated from the ovary. Implantation of ectopic pregnancy on the ovary is a rare event. Corpus luteal always arise from the ovary. Hematosalpinx or ruptured ectopic pregnancy may appear as an amorphous, solid, or complex adnexal mass lacking an embryo or sac. Moderate or large volumes of echogenic fluid or blood clots in the cul-de-sac are highly predictive of ectopic pregnancy. Blood in the uterine cavity produces cystic appearing mass termed a pseudo-gestational sac in 10 to 20% of ectopic pregnancies. A true gestational sac is differentiated from pseudo-sac by the presence of a yolk sac or embryo. A double decidual sac sign suggests a true gestational sac, but is not totally reliable because some pseudo-sacs may also show a double decidual sac sign. Pseudo-sacs are located centrally within the uterine canal, whereas a normal true gestational sac is eccentrically implanted. Subchorionic hemorrhage is a common finding in the bleeding pregnant patient before 20 weeks. The hematoma collects preferentially beneath the chorion because the chorion is more easily separated from the myometrium than the placenta. In most patients, a subchorionic hematoma is an innocent finding. However, an increased rate of spontaneous abortion has been reported in some series associated with large hematomas, advanced maternal age, and early gestational sac. The ultrasound appearance of hemorrhage varies with age. Acute bleeding is anechoic to hypoechoic. With clotting, it becomes hyperechoic and heterogeneous. With lysis, the hematoma reverts to being hypoechoic to anechoic. Retained periods of conception. The most common ultrasound appearance of retained periods of conception is an echogenic mass within the uterine cavity, representing retention of a portion of placenta. The mass like the normal placenta is more echogenic than the myometrium. A polypoid or pedunculated mass of retained placenta tissue has been termed a placental polyp. Blood clots appear as hypoechoic masses without blood flow within the uterine cavity. Variants in appearance of retained periods of conception include irregular thickening of the endometrium, thicker than 10 mm, highly reflective structures with shadowing, representing fetal parts or calcified placental remnants, or mixed echogenous masses representing necrotic tissue. Gestational trophoblastic disease is a group of neoplasms that range from benign to highly malignant. All are derived from abnormal placental tissues and occur as a sequelae to pregnancy. Hydatiform is the most common and most benign form of disease, but maintains a potential for malignant sequelae. Two types of hydatiform exist. Complete mole, which is called classic mole, which compromise 70% of cases, involve the entire placenta, lacks fetus, and is diploid in karyotype. Partial mole, which 30% of cases involves only a portion of the placenta, is associated with an abnormal fetus that is diploid in karyotype. This condition is lethal to the fetus. Rarely, normal fetus may coexist with a complete mole in a twin pregnancy. Prognosis for the normal fetus in this case is grim because of maternal complications of the mole. Ultrasound of complete mole in the first trimester classically showed the uterus to be filled with an echogenic solid, a solid highly vascular mass, often described as a snowstorm in appearance. As the vesicles enlarge in the second trimester, individual cysts which are 2 to 30 mm in size become apparent, producing a bunch of grape. The classic appearance of a mole is not always evident. Molar pregnancy may occasionally appear as an anechoic fluid collection that mimics an embryonic pregnancy. Fecal lutein cysts are seen as large, septated, bilateral cysts massively enlarging the ovaries in 25 to 65% of cases of molar pregnancy. Invasive mole refers to invasion of molar tissue into, but usually not beyond, the myometrium. Ultrasound shows penetration of the echogenic trophoblastic tissue into the myometrium. Choriocarcinoma is a highly aggressive malignancy that forms only trophoblast without any villus structure. Choriocarcinoma is locally invasive, spreads in the myometrium and parametrium, and hematogenously metastasized to any site in the body. Serum BHCG levels that rise or plateau in 8 to 10 weeks following evacuation of molar pregnancy suggest invasive or metastatic gestational trophoblastic disease. Choriocarcinoma at any site produces a highly echogenic solid mass. Fetal measurements and growth. Gestational sac size is used in the first trimester to estimate gestational age when no embryo is visualized. The gestational sac diameter is measured in 3 orthogonal planes and the results are averaged. Crown rump length is measured from the top of the head to the bottom of the torso of the visualized embryo or fetus. The crown rump length is useful until about 12 weeks of gestational sac. Biparatal diameter is measured on axial image of the fetal head at the level of the third ventricle and thalamus. The measurement is made from the outer table of the near cranium to the inner table of the far cranium. Head circumference is the outer perimeter of the fetal cranium measured in the same plane as the BPD. The head circumference measurement is relatively independent of the head shape, while BPD is affected by the head shape. Abdominal circumference is the outer perimeter of the fetal abdomen measured on an axial plane image at the level of the intrahepatic portion of the umbilical vein. Femoral length is the measurement of the ossified portion of the femoral diaphysis. Uterus and adnexia in pregnancy. Uterine leiomyomas are the most common solid pelvic masses encountered during pregnancy. Fibroids commonly enlarge and undergo cystic degeneration induced by hormonal stimulation as the pregnancy advances. Leiomyomas must be differentiated from the uterine contraction. Contractions are usually transient, although they may persist up to an hour. Contractions typically appear homogeneous and isoechoic with the myometrium. They bulge the inner, but generally not the outer margin of the uterine wall. Leiomyomas are persistent, more heterogeneous, may have calcification and typically bulge the outer margin of the uterine wall. Doppler ultrasound demonstrates spraying of the myometrial vessel around the leiomyomas, but no vessel displacement in the areas of myometrial contraction. Corpus luteal cysts are the most common cystic pelvic masses found in pregnancy. Internal hemorrhage causes enlargement up to 10 to 15 cm in size. Internal echos and septations. Most of these cysts regress by 16 to 18 weeks of gestational sac. Differential diagnoses include benign cystic teratoma, cystadenoma, hydrosalpinx, and ovarian cyst. Fecal lutein cysts form due to an exaggerated corpus luteal response to high level of BHCG. They appear as bilateral multicystic enlargement of the ovaries. They occur with their gestational trophoblastic disease, pregnancy with more than one fetus, or associated with the use of ovulation-inducing drugs.
So it's like ovarian hyperstimulation syndrome.
Yes.
It's the same, almost the same thing.
But one is associated with ascites. I don't
Not
remember.
always. Ascites can't be seen with it.
Yes.
You see ascites, it's also we can't be seen. The principle is the same. Ovarian stimulation by increased level of hormone.
Yes.
Cervical incompetence, preterm delivery is the single most common cause of a poor neonatal outcome. Ultrasound is used to measure and follow the cervical length and appearance. The normal cervical length is 26 to 50 millimeter throughout gestation. Cervical length is measured in sagittal plane between the internal os marked by a V-shaped notch and external os marked by a triangular ecodensity. The endocervical canal is seen as a thin hypoechoic or hyperechoic line. The relative risk of preterm delivery increases as cervical length decreases, with the greatest risk for cervical length of less than 2.5 cm. Cervical dilatation is measured between the anterior and posterior surface of the cervical canal. Dilatation of the cervical canal greater than 8 mm is indicative of cervical incompetence. Membranes may be seen bulging into the cervical canal.
According to this image, cervical length.
هذا
Measure just
this one, yes.
the above,
Yes. Yes, it is clear from this image
Between the
between
the arrows.
Yeah, the cervical, the lower part of the uterus and the cervix appears dilated. The membranes are bulging into the cervical
Yes.
canal. The remaining part of the cervical canal that
Is
is
short.
closed is very short.
Yes.
It is the whole thing of the cervical canal. Only this part is closed, still closed. So you measure this one. You can't measure the whole thing. The whole cervix is 35 millimeter and then you cannot do that.
Yes. Placenta and membranes. The normal placenta has a maximum thickness of 4 cm and a minimal thickness of 1 cm. Thick placentas are associated with maternal diabetes, maternal anemia, hydrops, chronic uterine infections, and placental abruption. Thin placentas are associated with preeclampsia, placental insufficiency, IUGR, and trisomy 13 and 18. Placenta previa is present when a part or all of the placenta covers the internal cervical os. Ultrasound confirmation of placenta previa is performed transperineally with the bladder empty to allow optimal identification of both the edges of the placenta and the internal os. When the placenta covers the entire cervical os, as in this image, the placenta previa is complete. While when an edge of the placenta covers a portion of the cervical os, the placenta previa is partial or marginal.
From which week we can diagnose placenta previa?
Well, for me, I think
Late second.
so. If you see any suspicion, for me, if you see anything that looks like a placenta previa, even in early pregnancy, of course you should follow it up. It's not an indication for delivery or preterm delivery or anything like that. You follow it up. As the pregnancy advance,
Just no polish.
yeah, as the pregnancy advances, usually it ascends. If it does not ascend at the late part in the pregnancy, then you are sure that this is placenta previa and it's an indication for cesarean section. Okay? Usually after 32, you can't make your mind. This will not ascend anymore.
And before 52 you can إشارة increase
No,
normal
no,
placenta.
cesarean stuff. Cesarean.
Vasa previa is present when placental blood vessels or the umbilical cord are adherent to membranes that covers the cervix. The vessels tear as the cervix dilates, resulting in fetal hemorrhage and death. Color Doppler is used to identify blood vessels fixed in place over the internal cervical os. Placental abruption is defined as the premature separation of normally positioned placenta from the myometrium. Subchorionic hemorrhage occurs because of a separation at the edge of the placenta. Bleeding is usually venous and peripherally accumulates beneath the chorionic membrane adjacent to the placenta. Retroplacental hemorrhage occurs with more central abruption. Bleeding is usually arterial and accumulates beneath the placenta as an anechoic or mixed hypoechoic mass. The hemorrhage may be isoechoic and difficult to differentiate from the placental tissue. The diagnosis is suggested by demonstrating disruption of the retroplacental complex of veins and thickening of the placenta more than 4 cm. Placenta separate from the uterine wall by heterogeneous hematoma. Placenta accreta is an abnormal adherence of the placenta to the uterine wall. Invasion of the uterine wall by the placenta is referred to as placenta increta, and penetration of the uterine wall is placenta percreta. Ultrasound is 50 to 80% sensitive in making the diagnosis. Placenta previa is usually present. The placenta itself appears full of holes, indistinct parallel vascular channels called lacunae, which show turbulent blood flow on color Doppler. These are distinct from normal placental vascular legs, which are more rounded and have organized laminar flow. The myometrium appears thin, and the sharp hypoechoic line demarcating the placenta from the myometrium is lost. The normal retroplacental complex of vessel is focally or completely absent. Chorioangioma is a benign vascular placental mass supplied by the fetal circulation. It is the most common tumor of the placenta. It appears on ultrasound as a solid hypoechoic, sometimes septated mass within the placenta, usually close to the chorionic surface. Spectral Doppler demonstration of arterial waveforms at the fetal heart rate in vessels supplying the tumor is diagnostic. Umbilical cord. The normal umbilical cord consists of two arteries and one vein surrounded by Wharton's jelly. It has a normal diameter of 1 to 2 cm. A single artery umbilical cord is found in about 1% of pregnancies and has a 10 to 20% associated with congenital malformation. Associated anomalies include cardiac, urinary tract, and CNS malformations. Omphalocele, the omphalocele, trisomy 13 and trisomy 18. Mass in the umbilical cord include arantoic cysts, hematomas, hemangiomas, umbilical artery aneurysm, and teratomas. Encirclement of the fetal neck by the umbilical cord, which is called nuchal cord, is usually a benign finding, but may be associated with cord compression, bradycardia, and very rarely fetal death. Placental membranes consist of outer layer, which is called chorion, and an inner layer, amnion. These membranes commonly remain separated by a layer of fluid until 14 to 16 weeks gestational cycle, when the two membranes fuse. The amnion is visualized on ultrasound as a thin membrane floating in the fluid. The chorion is identified as the membrane confining fluid within the gestational sac. Occasional persistence of chorioamniotic separation into the third trimester is believed to be of no clinical significance. Amniotic mass syndrome is caused by the early disruption of the amnion, enabling the fetus to enter the chorionic cavity. The fetus becomes entangled in fibrous bands that develop within the chorionic cavity. Entrapment of fetal parts results in amputation deformities that range from mild to incompatible with life. Typical abnormalities include asymmetrical absence of the cranium resembling anencephaly, encephalocele, gastrochesis, and truncal defects, spinal deformities, and extremity amputations. Uterine syncytiae are membranous structures that project into the uterine cavity, a characteristic appearance with a bulbous free edge, a thinner mid portion, and a thicker base. The fetus is able to move freely about the sheet of the tissue. No fetal deformities are associated with this condition. Amniotic fluid. Amniotic fluid index is a rough ultrasound measurement of amniotic fluid volume obtained by measuring the vertical diameter of the deepest pockets of fluid in the four quadrants of the uterus and adding these values together. Pockets are selected that do not include fetal parts or umbilical cord. Normal values are 5 to 20 cm. Polyhydramnios is an excessive amount of amniotic fluid. The diagnosis is usually made subjectively by visual inspection. Polyhydramnios is suggested by a large pockets of fluid related to the size of the fetus and the age of the pregnancy. An amniotic fluid index greater than 20 cm or a single fluid pocket greater than 8 cm is strongly suggestive of polyhydramnios. Another clue is failure of the fetal abdomen to be in contact with both anterior and posterior uterine wall after 24 weeks. About 60% of cases are idiopathic, 15 to 20% are related to maternal disease like diabetes mellitus, preeclampsia, anemia, and obesity, and 20 to 25% are associated with fetal anomalies. Gross polyhydramnios has a higher association with fetal anomalies than mild polyhydramnios. Associated anomalies include anencephaly, encephalocele, GI obstructions, abdominal wall defects, achondroplasia, and hydrops. Oligohydramnios refers to an abnormally low amniotic fluid volume. Fluid pockets are small or absent. Fetal parts are crowded. Fetal surface features such as the face are difficult to visualize, and the amniotic fluid index measures less than 5 cm. Measurement of the largest fluid pocket in the vertical direction of less than 1 cm is indicative of severe oligohydramnios. Causes of oligohydramnios include premature rupture of membrane, IUGR, renal anomalies, fetal death, eclampsia, and post-date pregnancies. A major complication of severe oligohydramnios is fetal lung immaturity. Multiple pregnancy, twins occur in one of every 90 births. Morbidity and mortality are significantly increased in twin pregnancy compared with single pregnancy. Twins account for 12 to 13% of all neonatal deaths. Relative risk is increased if the fetus share a placenta, which is monochorionic twin, as opposed to each fetus having its own placenta, which is dichorionic twin. Twins that share a single amniotic cavity, which is called monoamniotic twin, have the highest risk of morbidity, including conjoint twinning and intertwining of the umbilical cords. Visualization of the two separate placenta or determination that the twins are of different sex is definitive proof of the lower risk dichorionic twinning. The presence of two yolk sacs is evident of the amniotic twins. Unfortunately, about half of the dichorionic twins will have a fused placenta. Visualization of a membrane separating the twins confirms the diamniotic twins. Monochorionic twins usually have a vascular anastomus at the placental level, making them at risk for twin transformation, transfusion syndrome, and twin embolization syndrome. Twin transfusion syndrome results from shunting of blood from one twin to the other through vascular connection in the placenta. The abnormality ranges in severity from minor discordance in growth to severe IUGR in one twin, with hydropic fluid overload in other twin. Severe disparity in amniotic fluid volume may present, with one twin experiencing polyhydramnios, whereas the other twin is virtually unhydramniotic. A stuck twin compressed against the uterine wall by the amnion. The mortality rate is high as 70%. Twin embolization syndrome is an uncommon complication of the death of one twin in utero. Blood products from the dead twin are shunted through the placenta interconnections to the live twin, resulting in disseminated intravascular coagulopathy and multifocal tissue infarction. Fetal anomalies. Nuchal translucency refers to the normal equiescent space between the spine and the overlying skin at the back of the fetal neck. Care must be taken to distinguish between the amnion and the fetal skin. Recently, the nuchal translucency measurement has been refined to express nuchal translucency measurement relative to the gestational age or crown rump length. In the second trimester, a nuchal thickness measurement of larger or equal to 6 mm is abnormal. Nuchal thickness in combination with biochemical screening in the first trimester detects 80% of Down syndrome cases. Increased nuchal translucency in the fetuses with normal chromosome is associated with major cardiac defects, diaphragmatic hernia, and omphalocele. Trisomy 21 Down syndrome is the most common chromosome abnormality. Ultrasound markers include widened nuchal thickness, thickened nuchal fold, absent nasal bone, short femur or humerus, echogenic bowel, echogenic focus in the heart, and fetal pylectasis. Major structural defects found in Down fetus, including congenital heart disease, endocardial cushioning defect, ventricular septal defect, and tetralogy of Fallot, duodenal atresia, ventriculomegaly, and tracheoesophageal atresia. Trisomy 18 is the second most common chromosome anomaly occurring in one of 3,000 births. A large number of structural abnormalities may occur, but the most common identified by ultrasound are IGR, complex congenital heart disease, choroid plexus cysts, congenital diaphragmatic hernia, omphalocele, neural tube defects, Dandy-Walker complex, clenched hands, and single umbilical artery.
Okay, let's do it fast. So we have the central nervous system, face and neck abnormalities. First, you have to scan the brain at 3 distinct levels.
Yes.
You should know them all. The transcerebral, you know what planes. You look carefully for evidence of ventriculomegaly. Go to the next slide. For evidence of the ventriculomegaly, because up to 80% of them have some sort of associated anomalies. Okay, you should the separation of the choroid plexus. You should look for the choroid plexus. It should be dangling, hanging on the dependent part of the ventricle. If it's not hanging, if it's separated by more than 3 millimeters, there is something abnormal. You should look for abnormality.
Yes.
Okay, next please. And here, very common, unfortunately, a common abnormality is the anencephaly, which is the absence of all brain structures above the level of the orbit. You just see the orbit and that's it. Yes. Of course, it is lethal, always lethal. You should terminate. Next. And cephalocele, meningocele, myelocele is just presence of parts of the intracranial structures outside the cranium. If it contains just CSF, it's a meningocele. If it contains CSF and brain, it's a myelomeningocele, or cephalocele.
Yes.
If it is in the spine, it's a meningocele or the same thing, myelomeningocele. Next, please. So, spina bifida have either occulta or aperta. If it is just defect in the posterior elements without skin defect, it is occulta.
Yes.
It's very common. If we do a survey, most of us may have a spina bifida occulta. We don't know about it. Aperta, when there is something bulging from the skin, like a meningocele or myelomeningocele. Okay, and this will need surgery and follow up, and I don't know what. Next. So, Chiari malformation, you have Chiari 1, Chiari 2, Chiari 3, and the most important for us is the Chiari 2, where there is herniation of the cerebellum into the upper spinal cord, causing elongation and thinning of the fourth ventricle. Fourth ventricle is long and thin. Okay, and this will result usually will be associated with hydrocephalus. Next, please. Hydrocephaly.
No brain
The
tissue.
whole brain is replaced by fluid.
Yes.
The falx is present. Usually it's incomplete, but there is no brain parenchyma, no cortical mantle. Next. Dandy-Walker malformation and Dandy-Walker variant. Variant is a mild form of Dandy-Walker malformation. The cerebellum is open to the posterior fossa. Okay? Next.
Choroid
Choroid
plexus.
plexuses are very common. Most of them they resolve. However, most of the Down syndrome fetuses, they have choroid plexuses. So you should, when you see a choroid plexus cyst, you should look carefully for other
Systems.
possible indications for Down syndrome, because you might need some amniocentesis or something like that. What else? Cleft lip and cleft palate. Well, it's a very common abnormality. Usually, it is paramedian. It's not median.
Lateral.
Okay? Can affect the lip and the heart palate, or only the heart palate. Okay. If it is median, there is a whole different story.
Yes.
there is
Holoprosencephaly.
more severe form, holoprosencephaly and more hypothyroidism, I think, and things like that. Okay? You should look for the nostrils and the lip. Of course, the use of 3D and 4D ultrasound is helpful
Better.
in this regard. However, for me personally, I don't think you will get much use of it, because when you have a diagnostic cleft lip, you will wait till delivery and then send for the plastic surgeon. So you have nothing, you provided nothing to the patient. Next.
Cystic hygroma.
Cystic hygroma, it's due to abnormal development of the lymphatic structures of the baby. There will be some multisubtated cystic structure at the back of the neck. You can differentiate it by the presence of a septum
Yes.
at the middle, that it is not a meningocele. There is a septum at the middle. It is the nuchal ligament of
Yes.
the baby. What else?
Fetal
Fetal
height.
hydrops. Of course, all of us have seen fetal hydrops. It's just given everywhere in the fetus. Pleural ascites, subcutaneous edema, can be due to intrinsic or extrinsic factors, okay? According to the condition. Next.
Congenital
So-
diaphragmatic hernia.
Congenital diaphragmatic hernia, it's most commonly on the left
Side.
Okay? Next. Cystic adenomyosarcoma, we have type 1, type 2, type 3, multiple cystic structures in the chest of the baby, can be very small so that you cannot see them just as an echogenic mass, or can be less than 2 centimeters or more than 2 centimeters. So usually you just see an echogenic mass in the chest. It is due to CCAM.
And mixed form are common. Mixed forms.
This also can happen. What else? Pulmonary sequestration, we know it. There are two types, either intralobar or extralobar. Okay? Intralobar, both of them have supply from the systemic circulation. However, there is a difference in their drainage. Okay?
Yes.
Intralobar drain into pulmonary normally. Extralobar drains into systemic also structure, circulation. And absent stomach, usually by 18 weeks you see a fluid in the stomach. If you don't see, you have to wait for a
Repeat.
while, and there is scan again to check for the presence of fluid in the stomach, because the baby swallows amniotic fluid continuously. Double bubble sign is a sign of some obstruction at the duodenal outlet, let's say, not the gastric outlet, because one bubble is the stomach, the other bubble is the duodenal. So when you see double bubble sign, either duodenal atresia, stenosis, annular pancreas, things that obstructs the duodenum. Okay? And usually it will present with polyhydramnios because there's no swollen up. Next.
Bowel
Bowel
obstruction.
obstruction can happen in the fetus,
Yes.
usually due to meconium ileus or things like that. Meconium ileus, when you see it, usually due to cystic fibrosis. When it perforates, the meconium will spread into the peritoneum of the baby, and it will calcify, present as calcified
Cause
sheets of.
sterile peritonitis.
Exactly.
Echogenic bowel.
Again, the meconium ileus will present as echogenic bowel. You see bowel very echogenic. This is due to meconium ileus, which is usual indication of the presence of cystic fibrosis. What else? Urinary obstruction, a lot of causes. Most commonly is PUJ stenosis or obstruction, pelvic junction. You can have posterior referral valves if the baby is a male, keep in mind that, and will result in bilateral reflux nephropathy.
Renal
Renal cystic disease, you have
Multi-cystic disease.
autosomal recessive or autosomal dominant. Autosomal dominant presents with big cysts, while autosomal recessive presents with very tiny cysts that you cannot see. You just see an enlarged kidney. Echogenic. Okay. Gastroschisis and omphalocele. Gastroschisis is something not good, but easy to treat. Omphalocele is difficult to treat. Gastroschisis defect in the abdominal wall with small bowel loops bulging through the defect, while and the umbilical cord inserts normally. Okay, while omphalocele umbilical cord inserts abnormally into the sac of the herniation. Omphalocele is bad. Gastroschisis is good. Next. Sacrococcygeal teratoma is very common. Can be external, internal, or
Yep.
mixed. Can happen at any stage of the pregnancy. If you see it, it might enlarge rapidly, might cause difficulties in the delivery, might change it to cesarean and things like that. You should keep in mind. Next.
Skeleton.
Skeleton dysplasia is a very complex group of bony disorders that results in bone, short, long, abnormal, convex, concave, fractured bone, whatever. So any abnormality in the bone, it can be a skeletal dysplasia. Usually diagnosed by special software by the computer. You just the femur is long, I don't know what is short, and the computer will give you a possibilities because there are a lot of skeletal dysplasia. Next. Thanatotropic dwarfism, fatal. Usually presented by small chest, result in abnormal lung development, the baby dies. Next. Thank you.
Thank you.